Hi guys, I hope that everybody is well this morning. I'm just going to quickly go through COPD with you, chronic obstructive pulmonary disease. It's very important for us to know COPD because you will see it a lot in the wards. And when you generally think of, looking for a respiratory patient, what are you looking for? You're looking for a COPD patient or a patient that has pneumonia, right? Those are one of the most common conditions that you would look to examine a patient with. Um, the other thing is that when we did COPD in theme 2.1, we just sort of read through the slides just for the purpose of the ETT, and now we can't remember much about it, especially in terms of the pathophysiology. So we're just going to quickly go through it, and I hope this sort of helps to refresh your memory, right? So before we start actually going through the condition, there's a few things that we need to know in order to understand the pathogenesis. So firstly, we need to understand the dynamics of airflow in the lung. Number one, in order for inspiration to take place, we need the lungs to expand. This means that we are relying on the compliancy of the lung. Why do we need the lung to expand during inspiration? Because when the lung expands, it is decreasing the pressure in the lung. And in order for us to inspire or to take in air, we need air to flow from the atmosphere and into the lung, from an area of high pressure to an area of low pressure. So when the lung expands, the pressure in the lung decreases, atmospheric pressure is greater than the pressure in the lung, and so air can flow from the atmosphere into the lung. Okay, does everybody sort of understand that concept? Is it coming back? So during inspiration, the lung needs to be compliant meaning that it needs to be able to expand, because when it expands, the pressure drops and air can flow from the atmosphere into the lung because atmospheric pressure is greater. Now, that's in very, very simple terms. Now, during expiration, we are relying on the passive recoil of the lung, meaning the ability of the lung to recoil back into its normal size. And when this happens, what's happening in the lung? The pressure in the lung is increasing. So the pressure in the lung is greater than atmospheric pressure. And so all the air from the lung, the carbon dioxide that is, remember the capillary exchange. So carbon dioxide is flowing from the lung into the atmosphere, right? So do we sort of understand that concept that during inspiration, we have to have compliancy, and during expiration, we need to have elasticity in order for us to have elastic recoil. So in essence, we are depending on the stretchability of the lung tissue. We are depending on the stretchability of these airways, the ability to expand and to recoil, to expand and to recoil during expiration. Now, now that we understand that, the other thing we need to understand is that the airways are lined by mucus cells. And so we have these goblet cells that are present, and we have cilia. These are protective mechanisms for the airways. And we did speak about this in pneumonia when we said that the cilia are very important in order to move objects in terms of foreign objects and pathogens out of the lung as a protective mechanism. Now, in COPD is made up of two conditions. Commonly, we refer to it as emphysema and chronic bronchitis. You will read about a third condition called refractory asthma, but we're not going to discuss it now. Now, with emphysema, what's happening in the lung? This elasticity that we just spoke about, it's lost. So what's happening is that the wall, the wall that is between two consecutive alveoli, which are those little air sacs in the lung, is lost. So it's damaged. So there's no elasticity. And so you have these large air spaces that are formed because now it sort of looks like that one alveoli has expanded into another. So the space is bigger because there are these bulli that are forming these gaps, right? And they are filled with air. So there's air trapping that's happening. That's the idea in emphysema. The elasticity is lost, the wall is damaged, there's no elastic recoil happening, and you have these bully that are trapping in air. So the number of functional alveoli in the lung in emphysema is reduced. Okay, so this basically means that patients who have emphysema are going to have difficulty with what? With expiration, because there's no elastic recoil. So they're going to take a breath in, and the lung is compliant, right? So it's increasingly compliant now because elasticity is lost. So they take a breath in and the lung expands. And then it is unable to fully recoil. So, what's going to happen? Not all of the air is going to move out of the lung. So, what's happening? You have air still sitting in the lung before the next breath is taken. And so, you have this concept called air trapping. And it is this air trapping that results in chronic hyperinflation of the chest. And that is why in patients that have COPD, they have a barrel shaped chest. The definition of a barrel shaped chest means that there is an increase in the AP, in the anterior posterior diameter, in comparison with that lateral diameter. And this is simply because you have air that is trapping inside the lung tissue. And so, if you sort of place your hands on the patient's chest wall, you might find like this crackling under your hand. That's something called subcutaneous emphysema. Right. Let's not deviate. So we were talking about the pathogenesis of emphysema in the lung, and we said that the lung cannot fully recoil. So we have air trapping. And what causes patients to develop emphysema? There's two main causes that we speak about, but the number one cause is smoking. Patients that are chronic smokers, this smoking results in damage to the alveoli. And you get what? You get these large air spaces that are forming in the lung. That's the idea. That's the picture you should have when you think of emphysema. Okay, now that we are comfortable with that, and the second cause was an alpha 1 antitrypsin deficiency, but we're not going to discuss that one for now because the most common cause is smoking. Now, the second one, chronic bronchitis. What happens in chronic bronchitis? So, we did mention at the beginning that you have these cells that are lining the alveoli, mucus cells, you've got goblet cells, and you've got cilia. So, what happens is that you have number one, you have hypertrophy of your mucus cells in chronic bronchitis. And number two, you have hypersecretion of mucus in the bronchial tree. So there's basically two things that are happening in chronic bronchitis. The mucus cells are getting bigger and they are secreting more mucus. In simple language, that's what it is. And so because you have more mucus sitting in the bronchial tree, what does that mean? It means that the mucus lining is going to be constantly irritated. So what's going to happen when it's irritated? It's going to stimulate the nerves, right? It's going to stimulate the nerves that are lining the airways. And so what's going to happen? You're going to have the cough reflex. So you're going to have coughing that's happening. And so that is why patients with chronic bronchitis, they have a chronic cough that is productive of large amounts of sputum. And that sputum can be either mucoid or purulent. That's not relevant at this point. So the idea is that you're having hypersecretion of mucus. Why? Because in this condition, the smoking is stimulating what? Hypertrophy of the mucus cells and hypersecretion of mucus. And so, in order to get rid of the mucus, the nerves are producing the cough reflex. Right, everybody with me so far? So, the patient has a chronic cough. Now, also because you have these mucus plugs in the airways, it means that it's going to be more difficult for the patient to breathe. And so this is increasing the work of breathing. It means that the muscles that are responsible for breathing now have to contract at a much harder level They have to work much harder in order to get that same amount of air into and out of the lung. So that is why patients have dyspnea. They've got shortness of breath. Okay, so we are trying to understand this. So you have these mucus plugs, and the patient has difficulty breathing, and they've got a chronic cough, emphysema, and chronic bronchitis, and that's what makes up COPD. Now, just to touch on something else, right, so patients that have got this problem, if you have dyspnea, you're going to have what? Cyanosis as well. But this doesn't mean that every patient with COPD is going to have cyanosis. It just means that when the COPD is so severe that the patient has severe air trapping, such that the oxygen saturation of the blood is severely reduced, the patient is going to have cyanosis, right? Because you have loads of deoxygenated blood in the body. So it's both these conditions together that causes COPD. And if you think about emphysema as well, we spoke so much about air trapping. And when we talk about air trapping, we're talking about what? Trapping of carbon dioxide in the body. So that means you have a lot of CO2. And that is what is also producing the cyanosis, right? So we mentioned dyspnea and we mentioned cyanosis in these patients. And we say they've got a chronic cough as well. Now, before we move on to the actual examination, um, okay, I'm just thinking if I missed out anything. Uh, okay, okay, so we'll come back to it if I think of it. Okay, so when you are examining this patient, let's do it step by step. So you're looking at this patient, simply observing this patient, the general condition. Now, let me just make this statement. When you are seeing a patient in the ward or in hospital, that patient, they are not there because they have COPD. The patient is there because they've got an acute exacerbation of COPD. So patients don't just come to the hospital because they've got COPD. Because remember, COPD is a chronic condition. They are there because they have what? An acute exacerbation of the condition. Now, the patient is there, you are looking at the patient, what would you expect to see? So the patient may be in respiratory distress, meaning that they've got an increased respiratory rate and they're using their accessory muscles of breathing. What are the accessory muscles of breathing? Sternocleidomastoid muscle, and you can mention the rest, but let's just focus on the one for now. Right, so you must know the signs of respiratory distress, which is nasal flaring, right? Patients in children, in small children, you might find grunting. I know they did mention that in skills, right? Nasal flaring, you can say grunting. They've got an increased respiratory rate, so they've got tachypnea. They've got use of the accessory muscles of breathing. They may have intercostal indrawing, which is what? Indrawing of your, specifically the lower intercostal muscles, right? And what else? Cyanosis, right? So in severe cases of respiratory distress, the patient might have cyanosis because remember that you have an increased level of deoxygenated hemoglobin in the body. And as we just mentioned, in emphysema and chronic bronchitis, this would be the case. The next thing to note, so we said we looked at this patient, the patient looks unwell, they look as if they are in respiratory distress, and we've substantiated depending on what you are actually seeing, all right? And then on inspection, so what's noteworthy on inspection of this patient? A, they've got a barrel-shaped chest, right? This means that they've got increased AP diameter. We already explained that. Anything else that you could find on inspection? Yes, the patient has pursed lip breathing. COPD, the patient has pursed lip breathing. Wow, what does that even mean? It means that when this patient breathes, you will find that their lips are partly closed, or rather partly open. Okay, so what does this do for the patient? It increases the end expiratory pressure. Because remember, we just explained that in COPD, it's difficult for the patient to breathe out because elasticity is lost. So it's difficult for the patient to breathe. Okay, both breathing in and out is difficult, but patients generally have prolonged expiration because it's difficult. So when we breathe through these partly closed lips, pursed lip breathing, it increases the end expiratory pressure and helps to force air out of the lungs. Right? So we said patients have barrel-shaped chest, pursed lip breathing, and often when you see these patients, they are leaning forward with their hands on their knees. That's generally how the patient looks if you're just looking at the patient. Inspection. Now you are palpating this patient. What will you expect to find? The key thing here is reduced chest expansion. So when we talk about chest expansion, it means that you are putting your hands around the patient's chest cavity with your fingers together. And when the patient breathes in, you expect your fingers to move apart. And as they breathe out, you expect your fingers to move together. So patients with COPD have reduced chest expansion on palpation, and they've got Hoover's sign, right? Um, Okay, so basically, Hoover's sign, when you think about it, it has to do with this paradoxical movement of the chest. So when the patient breathes in, the chest is not expanding, it's actually moving your fingers closer together. That's the idea, right? It's paradoxical. And the reason why this is happening is because the chest is already hyperinflated. There's nothing else can happen there. Okay? The next thing is that patients will have a tracheal tug. Once again, it simply means that the trachea is being pulled downwards with inspiration, right? Anything else that you would expect to find in COPD on palpation of this patient? Okay, on percussion, what would you expect to find? So, when you are percussing a patient, it's as simple as this. The chest can be resonant, which is normal. It can be dull, which means there's a consolidation in terms of the lung. It can be stony dull, which means there's some fluid, or it can be hyperresonant, which means that there's more air than normal in the lung. So, in COPD, what is the lung? It's hyperresonant on percussion. Now, on auscultation, what are you expecting to find? Patients, when you in COPD, what do you expect to find? Reduced breath sounds, right? Because we just explained why. Breathing is not efficient, so the breath sounds would be reduced. You generally don't find wheezing in COPD, but what you do find is crackles. So the patient has early inspiratory crackles in COPD. Why? Oh, yes, this is what I was supposed to say. Oh, now I remember. Okay, so because in chronic bronchitis you have these mucus plugs in the bronchial tree, right? So what happens is the body causes the respiratory muscles to contract harder and to contract stronger. So what this does is that it causes air to move into the lung much more rapidly, so much faster at an increased pressure. So this causes rapid opening and closing of the airways. And this helps that air to sort of move through the mucus. So that's what's actually happening. And so you hear this rapid opening and closing of the airways, and that is actually what produces the crackles. Because we said crackles happen in inspiration, right? And we can say they are early inspiratory crackles, or we can say that they are late or pan inspiratory. Pan means throughout. So late or pan inspiratory crackles throughout inspiration. If it is early, it means that the problem is happening in the small airways. If it is late, it's due to something happening in the alveoli. And in COPD, the crackles are due to rapid opening and closing of the small airways. So therefore, it's early inspiratory crackles. Okay, guys, I hope this made sense to you. Just to quickly recap what we find on examination of the patient, we said patients are generally in respiratory distress. On inspection, they've got a barrel-shaped chest and they've got pursed lip breathing and they're generally leaning forward with their hands on their knees. When you percuss, you find that the patient has, okay, so when you palpate, you find what? You may find subcutaneous emphysema, but the key finding is reduced chest expansion and bilaterally, not like in pneumonia where we had unilateral decreased chest expansion. So this is bilateral, and the patient may have Hovis sign and they may have tracheal tug. There's no clubbing in COPD. Okay, just to note, because that can often be a confusion. Next thing on percussion, it's hyperresonant. And an auscultation, what type of breath sounds do you find? Bronchial breathing. No, reduced breath sounds and crackles, early inspiratory crackles. Okay, so let me just ask you guys this to conclude. You do the history, you do the examination, and then when you examine the patient and you're doing the focused general exam, you find or you notice that this patient has bipedal edema. What does this mean? So it's a COPD patient, you know that for sure, but they've got edema. What does edema have to do with COPD? It means that this patient's COPD is so bad that they now have right heart failure secondary to COPD. And right heart failure secondary to a lung condition is cor pulmonale, which we already discussed. And because of right heart failure, the patient has got what? Edema, and we said that is because of we discussed pathogenesis, and we said it was because of an increased venous pressure, because you have most of the blood that is sitting in the venous side of the system, it's leaking out because you have what? Increased permeability of the blood vessel, and so you're getting extravasation of fluid into the tissue spaces, and that is producing bipedal pitting edema in a COPD patient. Okay, guys, so I hope this was helpful, and let me know if you have